I'd like to officially welcome you to the Virtual Pathology Student Interest Group Virtual Pathology Symposium. For those of you who have seen us on social media, we are commonly known as PathSIG. My name is Lauren Miller. I'm the current president of PathSIG and an M3 at the Medical College of Wisconsin. Just before we get started, I have a few housekeeping items. So we are in Zoom webinar format. If you are going to use the chat function, that is only going to the panelists. And we ask that if you have a question during the sessions that you use the Q&A function at the bottom of the screen. Once you click it, it will pop up and you'll be able to type your questions, and then I will be moderating the sessions as we go through. As we get started, feel free to just type in your questions as we go. I will hold them until the end. And also, I added a little bit of a fun roll call to this session. I will be posting a couple tweets asking what country you're from, if you're a student, what year are you, and just if you're an attending physician, what your practice is. So keep an eye on our Twitter because we'll be interacting with you as the days go on. And also, if you're going to tweet at us, please use the hashtag. It's hashtag PathSIG Symposium. We would love to see everyone interacting on our social media as we go through the morning. And at the very end, I'll give a brief recap of all the polls that we have. So without further ado, I am going to introduce Dr. Kamran Mirza, who is our faculty advisor for PathSIG. So Dr. Mirza is an associate professor of pathology and laboratory medicine at Loyola University, Chicago, Health Sciences Division. He serves as the Vice Chair of Education in the Department of Pathology and Laboratory Medicine, Associate Program Director of the Pathology Residency Program, and the Founding Program Director for the MS degree in Medical Laboratory Science. An award-winning teacher and mentor, Dr. Mirza received the 2020 CAP Emeritus Resident Advocate Award and ASCP's Mentor of the Year in 2019. He was recently named the regional winner of the AAMC's Brownie Anderson Award for New and Emerging Educators. Dr. Mirza has been recognized as one of the Pathologist Power List honorees for 3 consecutive years. In 2017, he was named one of the top 5 in ASCP's 40 under 40. Dr. Mirza also serves on the board of directors for the Central Group on Education Affairs. Without further ado, Dr. Kamran Mirza.
Thank you very much, Lauren. I'm not going to keep you guys from Dr. Sitar, who I know is going to be the highlight of today. It is a pleasure to see you all. Good morning. The chat box was going so fast. Myanmar, Tanzania, Chile, like so many countries that I couldn't even keep up. As the faculty liaison for PathSIG and one of the co-founders of this group, it is my pleasure to welcome you all today. You are in for a treat. We have an amazing lineup of superstar pathologists. And really kudos to the entire PathSIG team, Lauren and her board of directors. I think the title says it all. Pathology is the unseen and the most indispensable part of healthcare. And in many ways, it is the best kept secret of healthcare, and we can't keep it a secret anymore. So whether it's an aunt with cancer, a cousin with leukemia, or a friend with COVID-19, what we've realized is that people don't know what pathologists do, what type of physicians we are, and what our role is in our loved ones' care, right? So we've all heard these stories. For all of those medical students who are thinking of pathology, we consider ourselves closeted because we don't tell anyone we want to do pathology. Since the second we do, it's going to be the same thing, that we're too social for pathology, that our communication skills must be very poor, or that, we'll never be found because we'll constantly be in the basement. And, this is, getting so old. These misconceptions are so yesterday. Let's talk about communication for a second. Would you like that, let's say that there's a patient and they have colon cancer and you have to talk to them about their cancer or report it. Do you want a person with poor communication writing that report? You definitely don't. In fact, communication is one of the most important things that a pathologist can do. And as you can probably see, and you will see for the rest of the day, that we're actually pretty social people as well. And then when I asked students, who are thinking of pathology, how they found pathology, and this was probably true for myself as well, typically there's just like 1 or 2 people in a class, which is fine. We don't need them to be too many. But these are the stories on how they find us. They stumble across pathology because they were trying to fill in gaps in their medical school curriculum. And they happen to do it with a pathology elective, usually because they think that the elective would be easy. And when they come to the elective, they realize that their mind is blown, that it's an amazing field full of intellectual curiosity and fantastic diagnostics, and even ancillary testing, right? So there's something for everyone here. It could be that their exposure was because they actually worked in the lab before. In the US system, they might have been a lab tech or a medical laboratory scientist, or they might have known someone who was a pathologist, like their aunt could have been a pathologist. But beyond this, like in mainstream media, nobody's really talking about pathology unless it's just forensics. And even that is very suspect because House is a pathologist and all the people who do forensic autopsies are pathologists. But it isn't necessarily the sexiest thing in medicine. And apart from all these anecdotes, very few people come into medical school thinking that they want to become a pathologist. And then what happens when they come to medical school? Well, we give them courses which are integrated, right? We don't even call them pathology, and they're usually integrated with medicine. Ours is called mechanisms of human disease, and that's great. That's exactly how it should be taught. But the word pathology is completely out of it, right? We've taken away histology for the most part. You guys do it on your own. And then when we think of the pathologist, we're not necessarily thinking of someone who is diagnosing individuals, but we think of someone who is teaching us the pathophysiology of disease. So in many ways, we're nowhere in the curriculum, but we're also kind of everywhere. And medical students have difficulty, obviously, in picking this up. You know, their usual exposure to pathology is step one. There's a PTSD associated with step one. They don't want to touch pathology as soon as they get into what they call clinical medicine, because after third year in the US system, why would they ever be concerned with pathology? But that's a myth because everything in clinical medicine pretty much is pathology and laboratory medicine, whether it be the biopsy result that you're waiting for, or whether it be the lab testing that you ordered in the morning, right? The majority of the patient's EMR is actually full of path and lab medicine. And now we're changing, reforming medical education, right? Where there are, you know, we are living in a post-Flexnerian model where in the early 1900s, there were these changes to medical school curricula in the United States. And now we're looking again at what the curriculum should be teaching. And all of the trends that are in medical education are focusing more on costs of care, on chronic health conditions, et cetera. And you know, in the conversation, on the table, pathology has to be part of this conversation because you can't do healthcare unless you understand how the lab works, right? Because we are the main consultant for your patient-facing teams. Without the diagnostic results and without the data that comes from pathology and laboratory medicine, you won't be able to make the changes that you need. In fact, if you think about preclinical training, the goals are to reduce the amount of time where preclinical training is done, which is fine, provided we can somehow expand our pathology training, right? We have to be able to understand that pathology isn't necessarily a preclinical field in the old school sense of the word, right? Because there's so much pathology that you'll be dealing with even afterwards. Think of the fact now that step one is becoming pass and fail. This has implications for pathology and laboratory medicine too. There's one camp that says that, well, there'll be no more pressure on step one, right, which is great. And because of that, nobody will care about pathology because that was the only reason they were studying pathology, right? I may or may not agree with that. And then there's the other camp that says that, well, it might be better for pathology because people will be studying it without the pressure of step one, and they might actually fall in love with the concepts of pathology. I'm hoping that that might be the case, but you know, the jury is out, we don't know. We do have a pipeline problem. In general, what people have written about, and this is a nice article in The Pathologist, and I put a QR code for all these articles if you guys want to see them. We do know we have a pipeline problem. And unless our medical students are exposed to the pathologists in their clinical environment, right? Pathology in their offices and in their labs, they may not know what pathology and laboratory medicine is. In fact, I know personally of many medical students who actually like the charm of surgery. And people don't realize that, you know, it's either the tactile charm of performing surgery or it's the intellectual charm of actually diagnosing patients. In clinical medicine, the way we teach it right now, unless you come for a frozen section or see the pathologist in action, it's kind of understood that the surgeon is making the diagnosis or your PCP is making the diagnosis. And of course they are, they're playing a very big role in what they're doing. However, many medical students actually now, after they go into, let's say, surgical residencies, some of them understand that actually pathology was what they were more interested in, but they just didn't have the right exposure to it. So we wrote this tongue-in-cheek commentary about Dissecting Brain from Brawn, where we made surgeons the brawn and pathologists the brain. And obviously this is meant to be kind of just kind of fun and jovial, but the idea is that many students have difficulty in trying to dissect out those differences. So then, you know, the case can be made for a universal clerkship. Do we consider that pathology be a universal clerkship? You know, just as psychiatry, for example, is. Every medical student needs to be able to understand if their patient is depressed, right? If you're an endocrinologist, and your patient is depressed, you need to know the psychiatric skill, baseline skill, to understand that they might need a psychiatrist. Similarly, a surgeon might need to know about the endocrine status of a patient based on their examination. So similarly, if all of those things are universal clerkships, why isn't pathology a universal clerkship? Why is it that pathologists are seen as the didactic teachers and not necessarily those diagnosticians that are actually central to patient healthcare, right? Why aren't they seen in their roles in multidisciplinary care? Because basically we don't have time to teach them. In fact, we don't think of pathology as a clinical specialty at all. And pathologists are guilty of this ourselves when we call our patient-facing colleagues clinicians. In many ways, we're clinicians too, right? We're putting together data in a patient's electronic medical record, analyzing it, and then putting together our morphologic and diagnostic findings together with that data. So we are doing a clinical assessment. And in many schools, when you do an orientation to third year, the clinical part of medical school, there's no orientation to the labs. But here, I'm showing you some pictures of the Scripps School of Medicine, our Loyola University laboratories. In our third year, when there's no pandemic, we are able to offer an introduction to the clinical labs. And what we found is that, and this is part of their third year curriculum, right? So they know if they're putting a chart in something in Epic, they know where those tests are coming, who the people are 24/7 working behind the scenes for our patients, right? And so we've explored many different things, whether it be expanding it into a vertical curriculum, trying to do it with radiology, which is the other diagnostic field, incorporating it with surgery, or trying to incorporate it with medicine. And in general, as the preclinical years are shortening, right, the time is shortening, this is going to become more important and harder to do. Which brings me to today. Well, we have resorted to a social media presence. Pathology is not antisocial at all. In fact, our social media presence on Path Twitter is amazing. And here, this is from non-pathology organizations. We're talking about the intersection of social media and medical education. And now, not only is it that medical education is on social media platforms such as Twitter, medical students are as well. And if one small little silver lining has come out of this horrible pandemic, it is that we have established a community which is online, and that community is celebrating pathology and pathologists and students who want to become pathologists as well. Last year, for this year, for the match, the previous match, we celebrated it with the hashtag Virtual Path Match. And next year, we will be celebrating every person in interview season right now with Path Match 21. So we are cheering them on, and we're very excited for their journeys. And this is one of the reasons why Emily Towery, whose handle is PathMove, and I, and along with a bunch of others, I'll show you some pictures, thought about this idea that most medical schools really struggle to have a robust pathology student interest group. And because everything was going kind of virtual because of the pandemic, why not create a very novel, one of its kind virtual student pathology interest group? And so PathSIG was created. This is the original board. Dr. Booth, whose picture is next to me, is a fellow currently and was a resident when this started. And the rest of this entire board, these amazing individuals, Emily, Phil, Matt, Brett, and Lacey, they're all residents right now, PGY1 residents. And this was the founding board, and they handed it over to this amazing board, which is current. You've already met Lauren, and there's Cullen and Ashley Rose, Jason, Emily, and Daniel. And so this is the current PathSIG board. I'm so proud of the amazing work that they've already done and they continue to do, including the symposium. And I will leave you with this slide, which very perfectly timed, Cullen posted yesterday. It is his revised guide to choosing your specialty. I always see these ones where pathology is kind of nowhere. And I love this because pathology is everywhere. You're interested in ENT, you can become a pathologist. You're interested in physiology, you can become a pathologist. You're interested in reproduction, you can become a pathologist, right? Every path can potentially lead to a subset of pathology. And so, I know that there's an amazing lineup of people, and I'm going to get out of your way so that Lauren can introduce Dr. Sattar. But my goal basically with PathSIG and with everything that we do is to make sure that pathology is one of the boxes that medical students have. And you can cross it out. You don't have to become a pathologist, but every person should be able to make an informed decision about whether pathology is right for them or not. And I'm hoping that today's symposium will really help you, give you the tools to make that decision. Thank you.
Thank you so much, Dr. Mirza, for that wonderful introduction. Now I'm going to throw it over to our keynote speaker, who likely needs no introduction, but I will read a short bio on him anyways. So welcome to Dr. Sitar. Dr. Sitar was born and raised in Chicago and completed undergrad, medical school, residency, and fellowship at the University of Chicago. He then remained at University of Chicago and is currently an associate professor and surgical pathologist who focuses on breast pathology. Along with clinical responsibilities, he is also actively involved in medical education, including the well-known work entitled Fundamentals of Pathology, or commonly known as Pathoma. So Dr. Sitar, we're going to have this in a more of a conversational question and a format. If you have any questions during the session, please feel free as our participants to type it in the chat box, but I will open it up to Dr. Sitar. When did you decide to go into pathology?
Okay, well, good morning, everyone. Before I answer that question, let me just express my excitement and gratitude for all of you today. I see there's a really large crowd and from people from all over the world. And so it's just an honor and pleasure to be able to spend this time with you today and this morning. All right, first question, Lauren. What was it again? Sorry.
When did you decide to go into pathology?
Okay, excellent. So just a little bit about my history and pathology, and I tend to ask this when I meet the candidates as well. But I actually kind of took a very long route to medical school and pathology. So just to begin, I initially, I would say my science medical career kind of began in high school. I did research as a high school student at Northwestern University, which was just a few miles away from where I grew up. And my mentor at Northwestern University was actually a PhD who did his PhD at the University of Chicago. So when I came to the University of Chicago as an undergrad, I was actually planning on doing a PhD and was going to get involved in just regular research, bench work. And the lab I ended up in was called the Bluestone Lab. It was an immunology lab. It's kind of a famous lab. It's in California now, but it was at University of Chicago at the time. And in that lab, there were many MD PhD students. And eventually they convinced me to go to med school. So I ended up in med school. Once I ended up in med school, I completed 3 years and I did a sub-I in internal medicine. I had my letters of rec all lined up. I was all set to go into internal medicine. And at the last minute, I made a decision that I wanted to take some time away from medical school. Kind of weird. I did like 3 years and a quarter, had like literally 8 or 9 months left before I graduate. And all of a sudden I'm like pulling the plug. Anyway, that's a whole separate story, which we don't have time to go into this morning. But I did leave med school for 3 years. And when I left med school, I actually happened to live in some third world or developing world, I should say, countries. And while there, I really got a feel for some of the suffering that was occurring in those places. And I decided to do international medicine and pediatrics. So believe it or not, I came back to med school 3 years later. I did 2 sub-Is in pediatrics and actually had a spot in pediatrics, and I was all squared away. And this was November of my 4th year. So what happens next? Interestingly, this is 2000 roughly. And very few people were going into pathology in 2000. There was this kind of like rumor that there were no jobs, et cetera, et cetera. I'm sure we've all heard them and we could talk about those maybe a little later. But anyway, very few people were going into pathology at that time. And I know this is going to sound crazy, but the American Society for Clinical Pathologists sent an email to all 4th year med students offering $1,000 stipend if they would do a pathology rotation. And I'll be honest, I chose to do that rotation because I actually was more interested in the $1,000 than I was in pathology. But eventually they connected me. I signed up for the rotation and they connected me with a private practice in a suburb of Chicago at a hospital called Lutheran General. And there I began my pathology rotation. Interestingly, I rotated with someone that Dr. Mirza knows, Dr. Taxi. But anyway, and essentially what happened during that rotation was I began to, as kind of was just hinted in the introduction, I began to get a little feel for pathology. Now, mind you, I did have some interest in sort of like, I always kind of wondered, what is pathology? Should, I see it on the list of possibilities. Should I go into it? Should I think about it? How would I even think about it? But it never occurred to me that I could do a rotation or anything. Eventually I end up in this rotation and it slowly started drawing me in. Interesting, like November of 4th year, by the way. I started enjoying the fact that like diagnoses were being made and the answer was sort of being determined at the microscope, and the interaction with so many different specialties and all the things that I didn't appreciate. Now, mind you, I didn't have the patient interaction that I was expecting in pediatrics and internal medicine, but very quickly I began to realize that, well, maybe I'm actually interacting with the patient behind the scenes and I'm providing a service that maybe I don't necessarily need to directly interact with the patient in order to provide. And it slowly began to grow on me. But interesting, and I just think about the force in a person's mind at this time, or what I was thinking at this time. I was beginning to really enjoy the specialty, but I was thinking, this is crazy, like medicine to peds to taking time away to eventually going into pathology. Everyone's going to think I'm nuts, number one. Number two, it's already November, so how am I even going to apply? But by the end of the rotation, I was actually sure that it really meshed well with my just my goals. And obviously, I ended up in pathology, and it's a longer story as to sort of how I ended up where I was. But that's basically how I got into pathology. So it was a little bit of a sort of a roundabout way, and I think many of us sort of go through that. But in the end, I got drawn to the ability to have some time to think, to make diagnoses, to interact with all different specialties without having to give up one or the other. And then, yes, maybe I didn't have the ability to interact with patients, but I still gained the ability to be able to provide an effect on my patients, which was really my goal in entering medical school to begin with. Sorry, that was a long answer to a quick question.
No, that was wonderful. Your story is totally fascinating. I think a lot of us can really relate to the suddenly finding pathology and completely changing our track. So I will throw it over to a next question. What would you advise to students who are interested in pathology, or some of our international medical graduates who don't have a pathology program at their country and are looking to match into another a program here in the States?
Sure. Well, let me just take a step back and just say that I think, and as was kind of already hinted by Dr. Mirza, every medical student, every person who's interested in providing care to a patient and making a difference in the lives of our patients should have some interaction with pathology. Mind you, it doesn't need to be a 3-month clinical clerkship. It doesn't even need to be a week-long, endeavor. But maybe a few half days just to tour the pathology labs, to spend a little bit of time at the scope, even if it's just an hour, to actually just see what we do, to see that we're actually receiving specimens with clinical histories. We're tying together the clinical puzzle. We're eventually trying to solve this and then provide a diagnosis. And then maybe like half a day to just join us at an interdisciplinary or multidisciplinary conference, which is something that pathologists are doing all over the world. So I think that in this meeting, or anybody who sees this meeting in the future, regardless of what you plan on going into, it's essential to take a couple days and try to do get a little bit of an exposure to pathology. So I'll start there. Now, once you have that exposure, or you've determined that this is sort of on your list of possibilities, then the next degree would be to do a rotation. And it's like any other field. You do need to do a rotation before you can be sure that this is the specialty that is going to be the right fit for you. So anyone who's interested in pathology, or who even thinks, hey, this might be something, a 2-week rotation, a 1-month rotation, it's just going to be necessary to be sure that that's going to be the right fit for you. I think you asked something about the international grads who maybe have a little less opportunity if they happen to be trying to rotate here. I know most international grads, have to come in usually as clinical observers. Many programs offer those types of positions. Of course, we're in a little bit of an odd circumstance now with COVID, but generally speaking, you should be able to find an observership at some institution that will give you the exposure necessary to again, make that important decision.
Great, thank you for that. I will segue, you kind of touched on this and how you interact with clinical specialties, and what is the importance that you see in pathology to providing direct patient care?
Yeah, okay, excellent. So let's just say that, look, medicine is not a silo, and the practice of medicine is not a silo. It is a team effort in which each subspecialty makes a contribution to the ultimate goal of of benefiting our patients. That's really what drives medicine. Let's look at medicine as a whole. And by the way, that's a very broad commitment. I mean, that's a very broad topic. You've got people who do research who are making a contribution. You've got the nurses who are making a contribution. You've got the social workers who are making a contribution. You've got the support staff that's making a contribution. You have physicians who are making a contribution. So before we even get to pathology, let's just make something very clear, which is that none of us work in a silo. We are all interdependent, and we all add a little bit to the puzzle in order to be able to solve or put together the big picture for what's going to happen with the patient. Now, once you appreciate that, the next thing is then, okay, within the specific area of medical subspecialties, where is your contribution going to be made? And, as again, each one is interdependent. The surgeon's not going to be able to work without the radiologist, and the pathologist cannot work without the radiologist and the surgeon. So everyone is making an equal and important and essential contribution. As far as pathologists are concerned, the contribution that we make is we're taking in all the data that is available to us from the clinical team. We receive a very unique opportunity to analyze tissues and cells and fluids. Anything that basically comes from the patient is going to be analyzed, and in a very scientific way, provide clinically relevant, reproducible, statistically, again, relevant data that's going to then drive the clinicians in their thought process and the surgeons in their technical process. So that's the type of interaction that I have and that all pathologists have with the clinical team. No surgeon can ever do a cancer surgery without knowing the diagnosis, and no diagnosis can ever be made without the pathologist making the diagnosis. Now, a patient can come in with a crazy mass that's ulcerating the skin, and it totally looks like cancer, and it smells like cancer, and it sounds like cancer, but it's not cancer until the pathologist diagnoses it as cancer. And that's an essential role, and that's a critical role. And without that, the technical skills of the surgeon aren't going to come into play. The clinical or skills of the internist is not going to come into play, et cetera. So we're all interacting with one another. I would say the only real difference between the pathologist and the rest of the world is that we have that limited patient interaction, which is a whole nother topic on and of itself.
Could you touch more on the limited patient interaction? Are there opportunities for you to ever interact with patients? Do you miss the patient interactions that you had in medical school and would have had as an internal medicine or a pediatrician?
Sure, wonderful question. I think actually this is like the big, the big elephant in the room, which is that for the most part, when someone says, I want to go into medicine, or I want to go to medical school, or they grow up with this dream of becoming a physician, invariably in the image of that dream or the image of that goal is this doctor-patient interaction. And we can't deny it. That's, it's what it really is, just it's the cornerstone of medicine. And so that is an essential question. And what I would argue is that, and what I've learned, I would say what I've learned through my experience and just understanding myself and having gone through becoming and going into internal medicine to going into peds to eventually going into pathology, is that the pathologist does have an interaction with the patient. However, it's not a face-to-face interaction. It is a behind the scenes interaction. The patient maybe doesn't fully get to see what the pathologist does, but the pathologist is providing essential data by which the patient could never be treated. So I never feel that I'm not interacting with my patients. When I'm sitting with my residents at the scope and we have an extra case and we're both tired and we want to kind of move on and maybe we'll do this one tomorrow, I'm always thinking in the back of my head, yes, we could put this case off till tomorrow and it probably won't have an effect on the clinical management of this patient, but there's a patient behind this paper and slides, and they need to know their diagnosis because they're stressed out and they're worried and they're wondering what's going on. And so the faster I can provide a diagnosis and the more comprehensive that diagnosis can be, I am having an effect on my patient. If my cases are well written, if they're on time, if I communicate in my reports. Clearly, that is an interaction with the patient, and it has huge ramifications on the patient's even just the psychological well-being and general wellness. So I don't see myself as not interacting with patients. I see myself as indirectly interacting with patients. Now, yes, so separately, are there times where I interact with patients? And believe it or not, it's not very common, but I actually do have patients come to my office. I do look at slides with patients on occasion. I do get those thank yous and those handshakes that, make that sometimes you remember your whole life. I mean, there are cases where I've had patients come and shake my hand and I will never forget their face, when they did that. But essentially what I tell the clinicians that I interact with, or, the surgeons that I'm interacting with in particular, is that any patient that ever wants to know what's going on with their slides, please let them know that I am happy to review their slides with them. If they have any concern, any question, want any further direction on what I'm seeing. And our surgeons know that. And I interact, on occasion, they do send people to me when there's a big decision that needs to be made. I would say, every few months or so, a patient will schedule an appointment and come to my office, and I'll review the slides with them. And that's probably the most interaction I have. But there are other subspecialties where you actually will directly perform a procedure on the patient. For example, in cytopathology, you actually will go to the patient's room and perform the procedure and meet the patient. Some hematopathologists actually still do their own bone marrow biopsies. So there are some opportunities. They're not as prevalent as in other subspecialties. But again, for me, I don't need to see the patient to feel that I'm benefiting the patient. I just need to know that I'm benefiting someone. And I find that within pathology.
Well, thank you. That's amazing. I think based upon the chat, there's a lot of people who are really resonating with the things you're talking about. So I'll turn over some of the Q&As that we're getting. What are some of your favorite and least favorite aspects of your career?
Okay. There's multiple favorite aspects. I love the intellectual challenge. I love that I am sort of given a bunch of clues, and then I have to put those clues together and come up with a story that matches the clinical history. So that's a huge plus to what I do every day. I love the fact that I'm able to make a difference in a patient's life. That's what drove me to go to medicine. That was what interested me in research to begin with. I love that I'm surrounded by individuals that are all highly caring and highly intellectual. And that's one of the benefits of being in medicine as well. But that's really something that I look forward to. I love being able to interact with the students. As a pathologist, you really do become, now remember that the word doctor actually means teacher, right? And so you really become a teacher. I am constantly educating the surgeons that I interact with, the nurses that I interact with, the oncologists that I interact with. I will tell you that anytime anybody has any kind of scientific, research-based, or other kind of question that would relate to, the science or mechanism of disease, they will call me. I have 65-year-old clinicians calling me saying, hey, what about this and what about that and what's actually happening here? And so that's also a very, very fulfilling aspect of what I do. What are the negatives? I think you asked for the negatives as well. I don't know. I know it's cliche to say what negatives. There's no negatives. I pull in the parking lot every day, and I think I shouldn't tell this publicly, but I just think I can't believe they're paying me to come here because I just really enjoy it. It's just such an honor, particularly to be able to interact with, to be able to benefit the patients. I think maybe one of the negatives is that I have a lot, I think the pathologist's ability to offer to the patient is more directly is sometimes not seen by everybody who's involved in clinical care. That when they want to advertise, for example, when someone wants to advertise the head and neck program at the University of Chicago, they'll put up a head and neck surgeon on an advertisement, or sometimes they'll put up the surgeon and the radiation oncologist on the advertisement and then sort of post up a billboard. And of course, that often skips over pathology. And I think that if the people sort of who are outside of the direct clinical care could appreciate a little more what pathologists do, it would strengthen their ability to engage with patients holistically, and would also strengthen the ability to understand how the entire sort of dimensions of patient care fit together. So maybe that's the one negative, is that those who tend to be outside in the more managerial and strategic roles don't understand sometimes what pathologists are doing. And that can be a little frustrating, because I think it doesn't allow us to maximize on our ability to sort of build strategies and come up with solutions for the greater healthcare system.
Great. Well, circling back to your education piece, what first drew you to academics, to practice? And the question everyone wants to know, how did you come up with Pathoma? What led you to write that book that has changed the lives of medical students literally across the world?
Sure, excellent. So as far as academics is concerned, I think that's kind of in my blood. Like I said, I was doing research as a high school student. I mean, how many high school sophomores do you know, like after school, like drive over to a lab and like are pipetting and sequencing DNA and cloning, which are all things I was doing in the 1990s. And so, you know, there's a big academic component to just who I am. I think, you know, that is part and parcel with my being in academics. As far as Pathoma and how it came about, it's a process. It occurred over a long period of time. I've always had an interest in teaching. I've always had an interest in sort of distilling ideas down to their most basic components. I think, you know, I mentioned I took some time away from med school, and I think that was really, really beneficial. I went through pathology the first time around completely unable to grasp 80% of the concepts, like all of us. I mean, there are no supermen or superwomen on this, you know, as a second year med student. I was totally overwhelmed. Couldn't keep up like everyone else. And for me particularly, it was difficult because of my research background, where you kind of get more time to think in a research background. So I went through pathology, you know, of course, tried to keep up, did the best I could. Eventually did take that time away. And when I returned, I was TA, and then I was TA again. And then as a resident, I TA'd the class again, this time from a resident's perspective. And eventually started realizing that many of the things that were the key components of what you should know were getting sort of like lost in the details of all the other things that you probably necessarily didn't need to know if you weren't going into pathology. And that eventually then led me to ask some sort of very basic questions, like what are the students even getting as a second year? What is the student getting from the course? So I literally, like, I remember 2006, this was 2006, I think June or something, May or June. I was in the final year. I was a fellow my final month actually. And I was walking around the pathology lab and we were doing our clinical pathology course, and I was TAing the lab. And I started asking someone asked me about lymphoma, and I turned the question around and asked, well, okay, so what is carcinoma and what's melanoma and what's sarcoma? And they couldn't explain carcinoma and sarcoma, even though this was like the last week of the course. They didn't really fully understand. They could tell me, you know, squamous cell carcinoma, papillary carcinoma, they could list off all the carcinomas, but they couldn't really just tell me that it was a malignancy of epithelial cells defined by the presence of keratin, you know, as an intermediate filament. And so I started thinking as I was walking back from that interaction that, like, this is crazy. Like, this person's been in this class for 6 months now, and they can't tell me like the basic, they can name and list every single carcinoma, but they can't tell me like the gist of what is a carcinoma. So I literally came back to my desk and I was like, you know what, they can't get carcinoma, sarcoma, melanoma. I'm going to make Pathoma. That was 2006. I then became an attending. I interacted more with the students, but I got sucked into the research part of my job and my career. And so I had no time for the next 3 to 4 years to devote at all to this. And then finally, you know, around 2010, roughly 2009, 2010, I kind of just said, no, I've got this itch. I need to get this out. I need to do it. And eventually I started putting together Pathoma. And, you know, on the side, I would do a lot of teaching, a lot of review sessions. I taught for other organizations in different parts of the world. Actually, I taught multiple countries. And eventually Pathoma kind of resulted from that.
Wow, I'm looking at the chat and it's just blowing up with everyone saying thank you for Pathoma. And I personally, I got through step 1 because of Pathoma. So you really have made such a wonderful impact. I want to transition more towards forward thinking now. How do you anticipate the field of pathology changing in the years to come?
Okay, very interesting question. So look, let's start with how pathology was and what it's become, and where then we can go about where it's heading. So initially, pathology was really a gross field, like not gross, a gross specimen field. Meaning what you would do is, the emphasis was placed on being able to look at the gross of a specimen, looking at a specimen and making a diagnosis. And honestly, there was a time where people would just look at the specimen and say, cancer, crab-like growth that seems to be pulling in a tissue, which is literally what cancer means. And so we started there. And then we progressed to developing skills with the microscope, where eventually we kind of went one step further and said, not only can we look at an organ and make a diagnosis, but we can go one step further and we can look at the tissue under the microscope and make a diagnosis. And then eventually we came to the point where we could look at cells and proteins by using something called immunohistochemistry. And now we've gotten to the point where we can say, we don't even need to look only at the cells, let's also look at the DNA. And so now we're talking about heat maps and RNA profiles and molecular pathology, DNA sequencing. And so I think what I would say is pathology is becoming more and more, quote unquote, micro. So we went from the organ to the cell, well, from the organ to the tissue, from the tissue to the cells, from the cells to the molecules. And so pathology is heading in that direction of being more and more molecular. So I can imagine, of course, you're always going to need to look at the gross organ. You're always going to need to look at the microscope. But I think that dependency on those things is going to decrease, and we're going to become more and more dependent on smaller and smaller particles in order to be able to make our diagnoses. And at the same time, I kind of see radiology like sort of chasing pathology in that regard. So radiologists before would be able to tell you, there's a shadow. And now they can tell you there's a shadow with increased blood flow, and there's a shadow with certain other characteristics, and there's a mass. And it's so amazing to me when I interact with the radiologists, because I do this obviously every day, that they can give really good guesses based on blood flow, MRI, and other modalities of what they think that lesion's going to be. And I wouldn't be surprised if eventually they came up with the ability to image to the extent that even a slide can provide some information. So I think, if you ask me like 200 years from now, I think radiology and pathology will be one subspecialty. But the future, there's no doubt that the future of pathology is heading more towards molecules. I don't think anybody in the world would doubt that. And I think 50 to 100 years from now, that will be really the basis of pathology.
There's a lot of people agreeing with you from the chat box. That's
okay,
for sure.
Excellent. We've got some fortune tellers online.
So looking at the job market, so pathology, it tends to be a 4-year residency and then 1 or 2 fellowships. And so that's a 6-year training program, where not the shortest and not the longest by any means. What sort of positions do you think are available for residents? Should they be looking at academics or private practice? What is the field on a broad scope?
Sure, that's an extremely important question, because really what you're asking is, once I finish residency, how am I going to make my contribution? Am I even going to have an opportunity to make a contribution through a job? And so let me just start by saying that there is a need for pathologists, there will always be a need for pathologists, and there are always jobs available for pathologists. The nature of pathology is that it's not going to attract the 50% of the class. Again, because that cornerstone of what drove someone to medical school was that doctor-patient interaction and that direct-to-doctor-patient interaction. So we're never going to be in the position, and this was kind of hinted at in the introduction as well, we're not looking to bring 50% of a medical class into pathology. We're looking to identify that 5% of individuals who are in medicine who basically say, hey, this is where I belong, and this is where I can best fit, and this is where I can make my contribution. Now, I know that we all like to talk about, oh my God, there are or aren't jobs in any particular specialty, and I will or will not be able to find my dream position, but I have yet to see at any time in my pathology career a circumstance where people weren't able to find a job that they enjoyed, where they were able to make a contribution, and where they were compensated appropriately for the efforts that they're going to make. I do realize that, there are these rumors that tend to sort of like leak out along the way that, oh my God, there's no jobs, or, oh my God, there's not a lot of jobs available. And interestingly, when I remember that I told you 2001, I did that pathology rotation because they offered money, et cetera. At that time, there was this big rumor going around that there's no jobs in pathology. And in fact, that was the reason why many of the graduates had felt that they shouldn't go into pathology, because this rumor was sort of all over the place at that time. And I remember when I was thinking about pathology, this is what some people were warning me about. But the reality is that when I finished my training, I had multiple job offers. And I see today, even my fellows today have multiple job offers. I had multiple job offers. Some were in private practice, some were in academics. And I decided to choose the job that best fit me for all of the dynamics in my life. So I don't think anyone on this call should be worried about what's going to happen, if I go into pathology. Pathologists are needed. They're absolutely necessary. A good pathologist is always going to be highly valued in any clinical setting. So that's not something to worry about. What is important to worry about is what's the right fit for me? How can I become the most effective contributor for my patients in this greater medical system? And if pathology is the answer to that question, then by all means, you should jump into it wholeheartedly. Generally speaking, pathology training, as you've already hinted now, you probably don't know this or remember this, but when I entered pathology, it was a 5-year mandatory training. Now it's become 4. So I was actually the last of the 5, meaning the last of the ones who were afflicted by the 5-year training. It's been brought down to 4. So I actually did 5 years of training and 5 years of training. My 5th year was a fellowship. So I did 5 years. Now what happens is you do 4 years, and almost everybody does at least a 1-year fellowship. Sometimes some people do 2. Honestly, people come ask me this all the time. I tell students, don't even count the years. Look, when you enter med school, you are in your dream world. You chose to be in this profession so you can engage patients, make a difference in people's lives, and do something that you find personally satisfying. That begins the day you enter med school. And for some, maybe even college. That begins the day you enter med school, which means you don't have to count anymore. You're doing what you want to do. You're doing what you love and enjoy. Why would we count? That's everyone's gonna, nobody remembers a year here or a year there. So you should do what you love. If it means doing 2 fellowships, it means doing 1 fellowship, 3 fellowships, whatever, don't count. You just need to continue to work, and you will eventually end up in the place that allows you to make the best contribution. And you're never going to be like remembering that 1 year. I don't think it's good to make a decision based on how long a residency is or a fellowship might be. I think once you enter medicine, you're in medicine, and that's really all that matters.
All right, so we're getting a lot more questions, so I'm gonna combine and kind of go through some of the questions. What advice would you give to students who are looking to try to parcel out whether they should go into a direct patient care specialty versus pathology?
Yeah, and that's a really hard, that's a great question, and that's a really hard thing to decide. I'll be honest with you, I was super torn. I mean, because like I said, I started well, first of all, I came into research in medicine because I wanted to benefit patients. All you hear from day 1 of medical school orientation is the doctor-patient interaction. So you kind of have this set in your mind. And it is nice to get the thank you from the patient and to see their eyes and face light up when you're able to do something beneficial for them. I don't, deny that. You cannot, that is a huge part of medicine. And so, yes, that's going to be lost. And I don't want to even sugarcoat that. Look, that's going to be gone. You're not going to have that. And so I think it's important for a person to be honest with themselves and say, what are the things that I need in my career that are going to make me whole and allow me to run this marathon, which is called medicine. Now, medicine is a marathon. It's not a 4 years of med school, 5 years of residency fellowship. It's 35 years of practice. So I think this is a key question. If you say to yourself, I can be very happy knowing that I'm making making an essential contribution to patients without necessarily being able to shake their hand and hear a thank you at the end, then that's worth considering. But if you're a person who basically says, no, I need that, I need to just be constantly meeting patients and talking to them, and that's what energizes me and makes me wake up in the morning and puts me to bed at night, then I would say pathology is not going to provide that for you. And that's totally fine. That's part of the elimination process. I'll tell you, I don't miss it's not that I don't miss it, but I don't feel a void that I don't have this direct interaction with patients, because I am interacting with people constantly. So I constantly interact with the clinical team, the rest of the clinical team. I'm constantly interacting with residents, with fellows. I have other things that I do in my life where I'm having constant interaction with people. And so for me, that's sufficient, and I don't feel a void. And I never walk into work thinking, I wish I could interact with a patient or two today. But that's me, and everyone's going to be different. And remember that there's always positives and negatives from interacting with having a patient interaction as well. When you interact with the patient and you want to try to get a piece of data, it does take time, energy, care, and concern, etc., empathy to be able to get that data. And there is a component to that requires effort. And if that tires a person out, then that might be an important characteristic to appreciate about yourself. So for example, if you go and meet a patient and it takes 20 minutes to get the piece of data that you need, and that's something that taxes you and you find tiring over time, then maybe it's better to be one step removed and say, well, here, the person who interacted with the patient gave me this data. I'm receiving all of the data in one place very quickly. And now I am going to make the next contribution towards this patient's care. So there is a degree of personality as well, and what you're looking for. And again, I mean, we're not going to deny that that's part and parcel with the specialty a person chooses.
Wonderful. So I've gotten a couple questions on technology and pathology. How do you foresee artificial intelligence or machine learning being involved in the field?
Oh, excellent. You read my mind. or I guess the chat box read my mind. So look, what happens first of all, there's no denying that artificial intelligence is not only taking over pathology, it's going to take over the entire world. And it has. From when you go on Netflix and it basically starts recommending next thing you could watch, or when you're on YouTube and it says you might also like, or when you buy something on Amazon and it says other people considered, that's all AI, that's all artificial intelligence, and that's not going away. That's only going to become deeper. I think the way that artificial intelligence is going to begin to integrate with pathology, now we're a little bit behind in all of this, it takes time, but essentially what's going to happen is today we analyze certain patient samples, and when we analyze those samples, we analyze them with a certain degree of clinical information, and we come up with a diagnosis. And I think where artificial intelligence will play its role is that it will create guardrails for us, so that as we're analyzing these different inputs, we are able to capture, it's going to ensure that we captured the relevant data. For example, I'm looking at a slide, and on the slide, there might be a little collection of cells in a corner that I didn't necessarily see. But the AI system also scanned the slide and highlighted this as a red zone that I need to analyze carefully. So it might give me that additional assistance of going back and saying, okay, did I analyze that red zone carefully enough? So it kind of acts as a guardrail. Maybe I'll make a diagnosis and it won't fit with the greater clinical picture. There might be 2 or 3 things that are off, and it'll raise a red flag and say, only in 0.006% of the cases could this actually be the possibility. Have you rethink what you did and confirm? So I think at this point, it's going to act as a guardrail, sort of like when you're driving a car that has some of these smart systems. It doesn't drive the car for you, but it tells you you're wavering, or you need to stop for coffee, or watch out, there's something in your blind spot. I think we'll start there. And then eventually, slowly over time, these things will become more and more sophisticated, where they'll begin to suggest diagnoses. But of course, in the end, the driver is still the one that's going to need to make the final decision, and that is going to be the pathologist. But by the way, this is 50 years from now. This is not tomorrow. This is stuff that we're slowly heading towards. These things don't change overnight, just like, and it's my personal view, self-driving cars is going to be a while. And interesting, I've spent some time talking to engineers about even self-driving cars, and they all agree it's like decades away. This is not going to be in the next couple of years. So it's going to be a process.
Wonderful. And so we are slowly but surely running out of time. Do you have any closing advice or closing remarks that you'd like to give?
Yeah. Well, first of all, again, it's a pleasure and honor to be able to spend this morning with you. I'm humbled that there's so many people on from so many different places. It's just wonderful. It's great. And thank you, Lauren and Dr. Mirza and the rest of the team for even having the concern and the energy and the time to put such an event together. Look, I think in summary, what I'll say is that, and I'll just kind of reiterating a point that I made earlier, is that we are all in the end members of a team whose primary and central focus is to benefit and serve the patients around us. And yes, we do need to take our particular interests and skills into account when determining how we can best fulfill that goal, but we should never lose sight of the goal. And that doesn't mean that anybody has to go into any one particular specialty. It means that each person needs to go into the specialty that's right for them. Because when everybody's where they belong, that allows the system to run most efficiently, which basically means the patients will benefit the most. So yes, we represent pathology and we want to encourage as many people to go into pathology as possible, but I even want to be a little more broad than that and just say that I'm not going to be excited if you go into pathology. I'm going to be excited if you go into the field that's right for you. That's really what I want to see. So if medicine is right for a person, I want to see them in medicine because that's what's going to be the best for our patients and that's what's best for the person. And if pathology is right for you, then we want to see you in pathology because again, that's what's going to be best for the patient and that's also what's going to be best for you. And if you're not well, the patients are not going to be served. And if the patients aren't well, then we're not doing what we aimed to do. So just the final remark would be, take the time to understand yourself. That's always difficult, especially in med school where everybody in the world is telling you what to do. Take the time to understand yourself, be honest with who you are, your personality, your characteristics, your skills. And then the next step is to take the time to understand all of the specialties around you. Don't exclude pathology because you don't know what it is. Keep it on the list, try to understand what it is. And then eventually, as you work down that paradigm, you'll put yourself in the right place. And by the way, this is not something that has to end the day you begin residency. There are numerous pathologists who actually became something else and then did a year of residency or 2 or 3, or even graduated from residency and then come back and become amazing pathologists. So we, as representatives of pathology, are saying in any way, shape, or form, whether that's at the level of choosing a residency or reassessing while you're a resident or after you graduate, just figuring out how you can get a better interaction with pathology. I mean, that's what we're here to do. We're here to serve in that way. So my hope from any session, and I tell this to all the applicants who come through when we're doing residency interviews, is that we want to see you thrive. Because if you thrive, the system thrives. And if the system thrives, the patients are going to thrive. And that's really what this is all about.
Well, thank you so much for giving us your time this morning. It has truly been an honor to be able to chat with you and just hear your story. It is truly inspiring and makes me feel so excited to be able to enter this field next year. Yeah, I'm blown away, and so is everyone else on the chat. So we are truly, truly thankful for taking your time and also all of the contributions that you made.
An honor and a pleasure to be able to spend time with everyone this morning.